When we think about the management of the wound, we always tend to focus on the wound itself. But in fact, that really isn't the issue. The first thing we've got to do is to make sure we've got the right diagnosis. So we need to know the cause of the wound, because if we don't know what's causing the wound, we can't take away that cause. And unless we take away that cause, that wound is never going to heal. So the first thing is to make a correct diagnosis. And in order to do that, you need to have patient history, a medical history, and a social history from the patient. Then you need to examine the skin, and not just the wound, top to toe, because there might be other rashes, issues that help me make that diagnosis. Then we will do some investigations, and those investigations help us to form the diagnosis. So we might do blood tests. We might check the circulation by using a Doppler ultrasound machine. We might do a wound swab if we think there's infection there, but we'd only do a wound swab if there are clinical signs of infection. We might do blood tests, looking for anemia, looking for other conditions such as diabetes mellitus. We might do x-rays or MRI scans to look at underlying cancer or infection. We might also take a biopsy if we do think there's a cancer in the wound bed. So we've got the history, we've got the examination, and we've got the investigations. And then when we've got all that information together, that's when we can make a diagnosis. And that's when your wound management plan starts. So then we would think about managing the wound. But before that, we've got to consider managing the whole person. Because the problem is not just the wound. The problem is, are they in pain? Are they worried about it? Are they anxious? Are they socially isolated because of it? So we've got to examine all those other things that relate to the patient. When we get down to the wound, we tend to be talking about symptom management here. So what we need to do is optimise that wound bed to enable the body to heal. Because people often presume that the dressings or the bandages do the healing, but in fact the body heals itself. The dressings just give the right environment for that to take place. So what we need to do is to look at the wound bed. So here we're looking to see what kind of tissue is present in the wound bed. Is it necrotic, sloughy? Is it nice healthy granulation tissue? Have we got signs of healing with epithelialisation around the edges? Then we'll want to know if there's any exudate, any wound fluid. Have we got a lot? Have we got a little? Because we want a nice moisture balance in the wound bed. We tend to have a lot of fluid at the beginning of a wound, or if it's infected, and that reduces over time to a smaller amount. But here then, with that wound exudate, that will help us with our wound management plan. Is there an odour present? And with the odour, we always speak to the patient, because quite often that wound might smell. I could smell it. If it was your wound, you could smell it. But because of the etiquette in the UK, people don't like to talk about smell. So quite often I will say to the patient, does the wound smell? And if it does, is it causing you a problem? Is it causing people around you a problem? So we'll assess odour. So we've got tissue type, we've got odour, we've got exudate in there, and as I say, the signs of infection. And the clinical signs of infection are an increase in exudate, a change in the odour or a new odour, and the skin around the wound will be hot. We used to talk a lot about peri-wound erythema, but peri-wound erythema, redness, can only be seen on a skin of light skin tones. So we don't need to talk about just peri-wound erythema, because in moderate and dark skin tones, the erythema is heat. So we need to palpate around the wound to try and pick up these clinical signs of infection. So the wound management is about the whole person and then the wound. But quite often as a tissue viability nurse, if I'm called to see a patient with a wound, all people want me to do is look at the wound and tell someone what dressing to put on. But in fact, that's the last thing I do. I read the patient's notes, I talk to the patients, I talk to the nurses, the doctors, carers if applicable, and I get all that information I need. Then what I will do, I will sit down with the patient and I will find out from them what is their greatest problem. Because I might know what I want to do to that wound, but it's not my wound, it's the patient's wound, the individual's wound. So I'll say to them, what is the biggest problem for you? It might be pain, it might be leaking, it might be the smell. So what we'll do then is focus on what is their biggest problem, and we'll try and eliminate that or reduce the impact of it. And then once we've done that, we'll move on to the next thing. Because then if you're able to do that with people, they then get confidence in what you're doing and they see that you're listening to them. You're caring for them, but you're caring for things that matter to them. So that's the way I would approach it. I certainly wouldn't say, right, you've got a venous leg ulcer, you're going to have this foam dressing on, and I'm going to put you in compression therapy. It's not that decision. I can offer suggestions to the patient, but actually what regime we use is to do with them. It's their wound, it's their body, it's their decision. So I will list the options that I'm aware of. I will list the pros and cons for each type of option, and then the patient then can ask me questions, obviously, and then between us we will decide on what regime going forward. Because in wound management, quite often there's many different ways to manage a wound, and they can all be correct, but they can be slightly different. So that way we manage the wound with the patient, with their choice, with their input, and then obviously with any wound management it's never a one-off situation. So although we might manage that situation, we then are going to go back afterwards to say, right, we chose this option. Is it working for you? Is it affecting your day-to-day activities? Is it actually giving you more pain? So we will revisit this on a regular basis, and we'll revisit the wound bed. Because is that necrotic tissue being removed? Is the slough going away? Are we getting more healthy tissue? And are we seeing signs of healing around the wound edge? So we have to reassess, because a wound management plan is not a one-off situation. It can be repeated weekly for many, many months until we get the right regime and we see positive signs of healing. So so I said to you, it's an interesting question because it's not a straightforward answer. So I hope that answers your question.